Good morning. My name is James Kohler, and I'm the Director of the Office of Research and Development here at Morehouse School of Medicine. My pleasure to also welcome you to this event today. We're looking forward to a dialogue and some collaboration that will go forward as we continue this fight against HIV. We didn't have a vaccine, and we still don't have an ultimate cure, but we have strategies that are in place that can sustain life and quality. And that's been a big achievement going forward. I've been for about 30 years in the 90s when we were just coming up with antivirals and when we were just still implementing universal precautions, particularly in the health field. I was in the dental field of care, but obviously the whole world needs to understand, particularly all of the health field. So hopefully today we can continue that process. But my role as the Director of the Office of Research and Development is to connect you with each other and to see how we can find funding, because nothing happens without funding, right? So we're thankful for you for sponsoring this program in particular. But going forward, as we go into this new era, it's important for us to find opportunities to be creative in terms of getting funding that we can continue the research that will then be implemented into the practice. So I welcome opportunities to meet with you and to look for opportunities that we can get some funding that will go forward with this process. So without further ado, let's proceed forward with our planned schedule today, and we welcome all of you together. Great day to learn. Thanks.
Greetings. Hello, everyone. Good morning. I think Maisha Standiford, and I am charged today to highlight the mission that we are embarking on, this new landscape that we're in right now. It's important to always remain vigilant, consistent, persistent. And as we talk about resilience, in the presentations, you will hear about resistance and also resilience. But we also have to remember to rest. To rest. Efforts that we're doing, again, we're talking about intersectionality and interdisciplinary, transdisciplinary. We're going to highlight some of the efforts that we're focusing on with our Ending the Epidemic project here, funded by Gilead Sciences, and also we're highlighting the Georgia Thrives campaign as we talk about eliminating the epidemic in terms of new cases in Atlanta and the South. We have our collaborative partners over in Louisiana with Xavier University College of Pharmacy. And of course, we're talking about educating, informing, and training the next generation of HIV specialists, clinicians, researchers, and community members. So we're excited that we have you online learning. We are excited to have people who are going to be dropping in throughout the day. And we're, again, excited for the community to be here. So again, as we share our information that we're collecting, we want to make sure that you continue to be resilient and vigilant throughout this process. So I'll transition over to my introduction of the keynote speaker. I'll talk a little bit personally and how I met Dr. Allison Hamilton. And so after my career at CDC, I went crazy out of reason and decided to go get a PhD. And I moved down to University of South Florida and fell in love in the Asian community. Based participatory research and focused on medical anthropology and being a PhD. And so I thought, okay, great opportunity, and worked at a number of research institutions. And after we that area, and it was a little difficult for me finding my place and my space in the VA. Some of you who have worked in that space, it can be overwhelming. But I tended to find people who were like-minded and also had similar based research. My time focusing on related equities with women's health throughout the diaspora, particularly focusing on cancer, but then also looking at the whole health aspect and becoming a research scientist at the VA with colleagues who said, well, you should look at this training program at UCLA. Okay, is it virtual? Because I'm in Florida. And I said, yeah, I think you also need to look at the scientist name, Dr. Allison Hamilton. She focuses on women's health research at UCLA. Oh. And immediately I felt, okay, I found my space in this large organization and really focusing on what I need to do in terms of sexual health and informing women, particularly Black women, within the system. And Dr. Hamilton mentioned there's a training postdoc fellowship at the institution, and I was interested in coming along and getting trained. And I'm like, sure, why not? Being flown out to LA, I'm good. Every few months, why not? But not only that, but having the connectivity, having the support, and having a mentor. Through the years, throughout my shifts and my spaces and my locale has changed, she's always been there. And so coming back to Barnes School of Medicine, I said we have to continue to strengthen our bond of personally, but also professionally. And EA was avoiding the opportunity there with my place in Florida, but also connecting with Dr. Hamilton. And so I would transition to Dr. Research Director in the VA Center for the Study of Healthcare Innovation, Implementation of Policy at the VA Greater Los Angeles Healthcare System. And she's a professor in residence in the Department of Psychiatry and Biobehavior, University of California, Los Angeles. She is also an honorary professor in the Department of Psychiatry and Mental Health at the University of Cape Town in South Africa. She received her PA in psychological and medical anthropology health from UCLA in 2009. Dr. Hamilton's research portfolio focuses on improving health services for vulnerable and marginalized populations by understanding people's lived experiences and implementing evidence-based and theoretically informed ways. She is a member of the Society for Implementation Research Collaboration and Associate Editor for Implementation Science Communications and on the editorial board and women's health issues. So, of course, I had to state that I'd be remiss to not only acknowledge her as a great mentor, and now she's a dear friend, and whenever I call on her and ask, can you come to and she's like, as long as the vegan food are good. And she had already lived up the vegan spot, so I'm excited and elaborated that we are honored to have her come all the way from the West Coast to deliver this important message that she has, and then assist us taking some breakout sessions this afternoon. So let us welcome Dr. Hamilton.
Hey everyone, good morning. Thank you so much for having me. Let's see. Yes. And again, thank you, Dr. Stanley, for having me. Very emotional introduction, and we do go way back. And I do think that story really illustrates the power of programs like that in terms of the networks that they foster and relationships that stand the test of time. And Dr. Crawford, who you'll hear from a little bit later, was also in that program. And there are a lot of people cheering us on at UCLA. You're getting back together. So it's really just such a joy and an honor to be here today. And I want to thank the Satcher Health Leadership Institute here at Morehouse School of Medicine for hosting this event, and of course, for you for providing the support for it. I've been looking forward to this day, and so I'm very happy that it is finally here. So I'm just going to do some orienting. Before I do so, I just make sure to express that everything I share today and everything we share throughout the day, these are my own perspectives. They do not represent the position or policy of the Department of Veterans Affairs or the United States government. I am here as a private citizen on vacation today, and want everything taken in that context. So we're getting into implementation science today. It is a specialized field in some ways, in the sense that there's language associated with it. There are concepts associated with it that may not be so familiar. And so we're going to get into some of that language, which I think will then be coming up throughout the day. So there's some orienting to what even is implementation science, why are we doing it, why do we care about it, talk a little bit about the goals and rationale for it. And then I'll get into some of the details that keep the components of this type of work, and then illustrate its relevance for ending the HIV epidemic, which our initial speakers have already spoken to very eloquently. So implementation science, I would say, is around the 20th year anniversary. So things started happening in the early 2000s, maybe you can think of like the late 1990s as a time when we were thinking about this idea of translational research. We're thinking, okay, we're developing these interventions. They need to make their way into care in terms of implementation in healthcare. And we used to use the language of translation a little bit more. But part of the problem with the translation language was that it sounded and actually was too one-sided. Like the researchers are going to figure it out, and then they're going to impart this knowledge to healthcare clinics, organizations, et cetera, and then they'll do what the researchers figured out. And that is not really what we want to achieve, and things don't work like that. So we wanted language, I think, to reflect more of the dynamic nature of this work and the fact that we can't do implementation without the deep partnership and collaboration of the settings where it's happening. And so the field started to develop. I just happened to be sort of in the right place at the right time between being at VA and being at UCLA and having a social science background, which ends up being very handy for implementation science. It's a great place as an anthropologist to be. And that gave me opportunities to develop kind of grow up with this field in a sense, and try to do as much work as I can within the implementation science space. So before I get into some definitions, you may, if you're familiar with this area at all, you may have heard this idea, this finding that studies take an average of 17 years to get from bench to bedside, so to speak. Way too long, right? We develop things, we test things, we do trials, and then it's taking far too long for those interventions to actually make their way into the routine care of people who are supposed to benefit from them. And so implementation science really developed around the premise that we need to speed things up. We need to do a better job of moving research-based findings and these interventions that have been tested and that are demonstrated to work. We need to try to get them to people more swiftly, more efficiently, still rigorously. And so that's really where the motivation came from. We spend all this money, the government and other entities have spent a lot of money working on developing the evidence-based for interventions, but if people aren't actually getting them, that's a big problem. So we want to speed things up, make things work a little bit more efficiently. So this field has been focused on the systematic uptake of research findings and getting practices into routine care. And what we look at, and to a large extent, are the influences of organizations and professionals on the uptake of these practices. So we still focus on patients, consumers, family members, caregivers, et cetera, but we have that additional lens on organizations where this is happening. The healthcare, the hospitals, the clinics, the community-based organizations. And we want to move these approaches from that clinical base into routine use. And there are many ways that we need to facilitate that. So we know that we can't just go to a clinic or a hospital and say, we've got this great intervention, here you go, and then they will do it. We know it doesn't work like that, right? We know people may or may not take it up, they may or may not think it's a good idea, they may not think it's better than what they're already doing. And so we have to support that process. And that's where a lot of the implementation science comes in, is how to support that process, how to facilitate using what we call strategies, which I'll get into in a few minutes, to give people a little bit more to go on in terms of how to actually use these interventions. So we use 2006 as sort of the marker of the field really kind of taking shape. That's when the journal implementation science started. So if a journal is kind of a sign that a field has become a field, then that's kind of how we use that marker, which is why I say we're getting into our 20th anniversary of this type of work. So as I mentioned, when we try to introduce things into different settings, there are going to be barriers. There are going to be things that get in the way of using those interventions. There are also going to be facilitators, things that will help. Maybe you have a champion who says, I love this intervention. We were working on an intervention that was focused on HIV serodysphoric couples, where one person in the couple was living with HIV, the other person wasn't. And we were going to HIV service organizations, and they said, that's great. We don't have anything for couples. We don't really work with people who aren't living with HIV. We focus more on people who are. We love the idea of this intervention. We don't really know how to do it. Just filling a gap that the organizations had identified in terms of working with couples, working with people who were not living with HIV but were potentially at risk, or given the nature of the serodysphoric couple. Leaders in terms of we've never done anything for couples, but also the facilitators in terms of an attitude like we're into it. We like this idea of working with couples. So one of the things that we pay a lot of attention to in this field are those barriers of facilitators, identifying them and then figuring out how to address them. And that's where the strategies come in to try to overcome the barriers and then build on the facilitators that might already be there. I think one of the things that makes it really interesting to do this type of work as a social scientist is that it's very much oriented toward change. So if we find that a context, a setting, a clinic, an organization isn't open to it, but they're not ready, they don't necessarily have the knowledge that they need, maybe they need some resources, they need other types of support. We're actually in this field trying to change things. We're trying to facilitate and support their ability to change. So we're not looking at that setting, that context as a static thing that can't be changed and that shouldn't or wouldn't be changed. Actually looking at as something that we really want to understand and then do whatever would be appropriate and relevant to facilitate that adoption in that setting or across settings. So the NIH has historically supported implementation science very extensively, to the point where now there is a specific standing program announcement for implementation research. It used to be, sort of an ad hoc thing. Now we have a whole standing committee that reviews the studies that are implementation related. And what they even say in that program announcement is that we're not orienting enough resources toward the implementation side. We're orienting most of our resources toward that early testing and not orienting as much toward moving things into practice. And we need to ensure that the people who are getting care are getting empirically supported, effective care for their healthcare conditions. So one of the things that we use a lot in helping people orient toward implementation science is this idea of a pipeline. And for those who are familiar with research, this might be a little bit more familiar. For those who are less familiar with research, this might be a little newer, but there has been this idea that we go through a process of testing things, demonstrating that they work under controlled conditions, then moving them into less controlled conditions, looking at the effectiveness, and then finding out, okay, if we put this demonstrated intervention into place in a different setting, is it still going to work? How does it work? For whom does it work? How can we help it work, et cetera? So we focus a lot on that yellow box implementation, typically after the earlier work has been done, after we've done maybe some trials, different types of trials. I really like this pipeline. It's called the subway line model that Megan, my colleagues prepared to ask the question of, when is it time for implementation research? It's a really helpful way of thinking things through. When I talk about interventions, that's a pretty broad term for the types of things that we look at. In implementation research, there can be policies that we're looking to implement, drugs that we're looking to implement, as we see often in HIV-related research with PrEP and things like that. There are, let's say, mental health interventions, diabetes interventions, a variety of psychosocial interventions. So those would be what this particular formulation calls the practice of interest. And what we're trying to do is figure out, is that practice of interest kind of ready to look at these implementation-related questions? And so this can really help to identify what type of research do I need to do with my intervention, depending on where it's located in terms of this idea of the evidence. Is there enough support for it? It's an intervention before it's terms and ideas that you will be hearing throughout the day. So bear with me as I talk through some of these things that may be a little bit less familiar for folks who haven't heard of implementation research or maybe project. But I try here to break it down into components that are hopefully, just kind of have a lot of basic. So what we do in implementation research is address some type of problem or gap. People aren't getting a certain type of care. Maybe that type of care is not of high enough quality. Maybe there's a gap in services that we need to fill. There's something that needs to be changed. And as I mentioned, we're really focusing on change in this field. And we do use theory. And that's not meant to be intimidating or inaccessible. Really, the idea with using theory is that we want to develop an idea of, if we put something in place, here's how I think it will change. And we think if we help people with preventing diabetes, help people with pre-diabetes, not move into having diabetes, if we support them with a number of different interventions, they will not get diabetes ultimately. So that's a theory, right? And so what we go about doing is seeing, does that theory actually hold up when we test this, when we implement it? And so even though sometimes theory can be a little intimidating, we all have theories all the time. We're always working with theories. Maybe even if we say, I'm going to take this route instead of that route today because the traffic here looks bad, but over here looks okay. That's a theory. Right? But our theory might not pan out because we might get on that other and realize, oh my gosh, now everyone's trying to do this, so now I need to go another way. These are all theories. We have ideas about what is going to happen, and what we do in implementation research is say, did it actually happen the way we thought? So that's where that theory comes in. It can get after people if we think about it in that way. Then we need our ways of addressing the problem. We have an intervention. This is one of those ways that we're thinking about addressing the problem. And then we have what are called strategies. We use different study designs to help address that problem and evaluate how we're doing, because we need to ask that question of, did we actually achieve the change that we're trying to achieve? And we can only do that through evaluation. And we want to look at a whole range of outcomes. So what we do is, I'll talk about a little bit more in a moment, is not only look at, did it work? That's a question of effectiveness, but was it acceptable? Was it feasible? What about the cost? So we look at a range of what we call implementation outcomes, in addition to asking questions of effectiveness. So when we develop our research questions in implementation science, we start with, what is it that needs to be changed? What is that gap? What is that problem? What is that disparity, et cetera? And what are we going to do to address it? And then what types of intervention practices can we use to address it? What's available to us? Is there an implementation practice? So in the case that I mentioned of our intervention to support the needs of HIV surrogate couples, we had an intervention that had been developed. It was something that we already knew would help to reduce risk behaviors and reduce the incidence of seroconversion. And then we want to look at what's influencing the use of this practice. What else can we do to facilitate its use, and how are we going to know when what we did actually worked? How are we going to know that it was effective? So things get a little tricky as we move into some of the research parts of doing it. Implementation work. We can still use a lot of designs that we might be familiar with. So they're all possible, but as I mentioned, we want to look at more than just this question of does it work. That's not earlier stage of that pipeline. And when we look at an implementation research is, do people want to do it? Are they going to do it? Are they going to adopt it? Is it appropriate for the population? Is it appropriate for the setting? Is the cost going to be something that an organization or institution can absorb and can manage? Is it feasible done in a particular context? Is it feasible? And so when you talk to people before you start to do something, like one of the first things that we ask when we're doing interviews with people is, what's going to make it hard to do this here? We may know from other studies, but here, where we've never done this before, what is going to make it challenging? And that would vary a lot depending on where you are. When we do studies across sites, pretty much every site we go to has a different set of things that will say, well, this is what's going to make it challenging here. And then we go to site B and they say, oh, that's going to be no problem here. But this other thing that we're telling you about, that's what's going to be challenging here. And so you really need to get that context-specific sense of what the challenges are. So look at things like fidelity. So is the intervention being done in the way that it's intended to be done? Are adaptations being made? That's a big thing that you look at in implementation. It's meant to reach. So we have this idea that we want a certain population to get the intervention. Is it actually getting to them? And what might be getting in the way of it getting to them? We also look at sustainability. So the idea isn't just to put something in place and say if it's feasible, if it's acceptable, people like it, they keep wanting to do it. Does it actually stay in place? And might we need to support that sustainability and say, what can we do to help it remain here? So even I go back to the case of the intervention for couples, we proposed to study sustainability, which was unusual at the time, to say we're going to see what happens when the researchers aren't doing so much. And they want to sustain that input in most cases because of the structure of the intervention and the other pressing issues that they had in the clinics. That they said, we'd like to keep doing it, but if we have to choose between continuing to do that or doing this other part of our services that are, sort of non-negotiable, we're going to do the non-negotiable services. So we need to understand that sustainability question as well. And we use for our evaluations usually mixed methods. So we use some combination of qualitative and quantitative data collection and analysis to do our implementation evaluations, which again is why it's a great fit for someone like me and several others in the group who are social scientists, because we have that background, especially in qualitative methods. And one of the things you might hear about if you're, getting familiar with implementation science is this idea of hybrid study. And I won't get into the details here because I don't think we need too much of this today. But I just wanted to orient you to that language. As I mentioned before, one of the main motivators for implementation science was the length of time it was taking for things to make their way into care. And so a colleague of mine, good friend of mine, Jeff Curran, started to ask this question of, well, what if we do things at the same time? What if we don't do all these years and years and years of trials and then finally get to implementation? What if we combine our questions and say, let's find out if it works in this new setting and ask about these implementation questions at the same time? Really kind of a shift in how we do research. And that's what a hybrid type of approach means, is that we're asking more than one question at the same time to try to make their way into routine care more quickly, more efficiently. So there are different types of hybrids. This is something we can get into later, but I just wanted to orient and to that idea and why we even think about it, so that when we talk about possibilities later, this won't be super unfamiliar. I mentioned strategies, implementation strategies, and that is one of these terminology things that may not be super familiar. What we mean by strategies are methods or techniques that help with adoption, implementation, and sustainability. And there are a lot of them. So the one that we might immediately think of is education. If you're introducing something new in a different setting, you need to educate people about it. That's just a given, right? But if we say all we're going to do is educate people about it, not going to be, it may be necessary, but it's not going to be sufficient. So we can all be educated about things that we could do in our lives, that we do in our lives. That doesn't necessarily mean that we do them. It just means that we know about them. And so we need to add to that education with other forms of support. So we can't just expect to go to a clinic, go to a hospital, go to a community-based organization, say, we're going to teach about this, have a good time now that we've talked about it and measured it, and now you know more, and so now you can do it. It's just not going to be enough. It will be very important to educate, but we need to add to that with other strategy tools. Maybe you have an electronic medical record that's going to help support the implementation. One of our key strategies is sometimes what we call stakeholder engagement. What you'll hear from our amazing panelists and experts joining us today is the role that community-based participatory research can and does play in implementation research. So one of the key things we have to do is engage people in what we want to do. And list their support. We can't do this without you, and you're going to hear fantastic examples of this throughout the day. And so what can we do to how we all? And not everyone comes right. As we know, not everyone's like people who are suspicious. There are going to be people who are resistant. There are going to be people who are, maybe on the fence a little bit. And I'm not saying you'll win all of them over. Sometimes they won't, but maybe that you're offering a particular service, intervention program is going to be helpful for their constituents I'd be like, I'll wait and see, but I will listen to you. And even that is a great door to. And so we really spend a lot of time engaging people within organizations to support implementation. And there are many others here. There are, lists of strategies that number in, 70 strategies, 80 strategies. So it's a lot to take in. Basic point that we want to take away here is that number one, we need strategies. And number two, we usually need more than one to be able to make things happen. Again, theory, models, frameworks, I don't want to get too into the weeds here, but it is an important part of how we do implementation research, and it can be one of the more confusing and intimidating aspects of this type of work, because not everyone has familiarity with theory, and also it might feel like, oh, that's not something that I need, or that's not something that I do. But actually, theory, models, frameworks are really meant to be helpful. So again, we have ideas about how we're going to change things. We can draw on established theories, like you may have heard of social cognitive theory, theory of planned behavior, things like that from public health. And we also may need frameworks that help us to figure out how are we going to phase this work. So we want to have an approach that is systematic and that gives us different things to do at different times. So we think about, for example, what we call pre-implementation, before we introduce things, before we try to change things, that we would want to use certain strategies during that time. So it might be that you need both a theory and a framework, and where these come into play is they help to design our evaluations and figure out what methods we need. So there are a lot. I put a lot of acronyms here just because they can get kind of ridiculous. There are so many acronyms that we use. I've been doing this type of work for a couple of decades, and there's no way I could be well-versed in all of these theories, models, and frameworks. So don't feel like, oh, I don't know what those are, I can't do this. No one's going to know what they are. The great tool tools, an amazing web tool, that first one, where you can literally plug in what you're trying to do, who you're trying to do it with, what the focus is of how many ever 100 theories, models, and frameworks. Here are a couple that should be a good fit for you. So you don't have to do the work of reading about all of them and learning about all of them and figuring out which one is right. You can use that tool or the other tools listed here to help you figure out what is going to be a good fit for your work. And then there's also a really nice, I'm a really practical person. I like to make things doable and accessible and approachable. So I love, lists and frameworks that really help us think about how can we do this. This is one of those very handy sets of recommendations for how can we use frameworks. I believe there's even a worksheet with this paper that's available, open access. And so it really walks you through how to do this. So all these tools that help us to actually make this type of work happen can be really helpful, especially for people who are newer to it and learning, how to do it. So just to recap, this is again from my friend Jeff Curran, is he was presenting this at a conference one time, and everyone was like, "Oh, you should really publish that because it helps make sense of everything." And so the article is called Implementation Science Made Too Simple, and the non-scientific language is really the way to go, especially this can be very helpful if you're going to a community-based organization and they don't necessarily want all that language I just shared with you. Okay, what we're focused on when we are asking effectiveness questions, we're asking whether that thing works. And when we're doing implementation research, we're looking at how to help people do that thing. The strategies are what we do to help people do the thing, and our outcomes are how much and how well things is done. So really breaking it down, really making it much more accessible. So what I'd like to do now is just shift briefly into the relevance of implementation science for ending the HIV epidemic. We have had the Ending the HIV Epidemic initiative since 2019, the goal of which is to reduce the number of new HIV infections in the US by 75% by 2025, and then by at least 90% by 2030. This has been called a whole of society effort. There are many, many federal and other institutions involved in the EHE initiative, and there's a special issue of the journal called JADES for tons of background and current implementation science efforts. I highly recommend it, and I believe it is open access, so anyone can take a look at amazing set of papers that are in that journal. So the NIH strategic plan for HIV and HIV-related research. If we look across this institution, our 5 components of the strategic plan, which were on that website as of last night, are to reduce the incidence of HIV, develop next-gen therapies, conduct research toward HIV cure, examine HIV-associated comorbidities, and advance cross-cutting areas of research. And you see implementation science is right there in those 5 points in the NIH strategic plan. So just to take you back a little ways, back in 2013, Russ Glasgow and others said that if we're going to control the epidemic, we need to bring successful interventions to scale, and we also need to tailor them to vulnerable and marginalized populations and understand the context in which interventions are delivered. So this was earlier in the field of implementation science, with this idea that we've got to do the work of implementation to really make sure that we are tackling and achieving our goals in ending the HIV epidemic. If we flash forward, let's say, a decade or so, there have been several systematic reviews looking at research in the HIV and implementation space. And what we found across many different systematic reviews, including systematic reviews outside the US, is that a lot of these studies aren't using theory the way that they could. The implementation outcomes that they typically look at are acceptability and feasibility, so there's still a lot of room for improvement. And most of the interventions that have been studied focus on HIV prevention. And that's been similar across the board with these sort of scans of the work that's been done over a number of years. There's a more recent paper that says if we're going to, again, do what we want to do in terms of ending the HIV epidemic, we need to really think about the questions that we're asking and how we're asking. Points from this very important paper is that, again, we've got to include community and stakeholder perspectives, and we want to start with our end goal. So we need to start with that big picture. What are we trying to achieve? And then work on our way and use participatory methods. And again, we have amazing experts with us today. We're going to share their experiences and portfolios of work in this area. So I couldn't be more excited for our panels and to hear from the folks who Dr. Stanley brought together to share their work with us today. This perspective also acknowledges the diversity of context where we're trying to do this work, the complexity and the dynamic nature of this type of work, and the fact that this is a field that continues to evolve. So even the things I've shared with you, they're growing, they're changing, theories are being combined, theories are being added, theories are being tested, strategies are being tested. All of these things are moving all the time. Nothing in this work or anything we do in research for that matter is static. So I want to come to a close by just highlighting this idea of citizen-engaged HIV implementation science, which is something that I feel very sympathetic toward. I think is a really really interesting idea, and I thought it might be something that we want to build on during our workshop today, which is around this idea of involving communities and citizens in the development and growth of HIV implementation science. That is really what's this work equitable, and that's what's going to make this work effective in terms of bridging divides. We can't do it without communities, without citizens, without people who are affected. Implementation, honestly, the field has been maybe a little slow in picking up on that. And so it's very exciting that this is now more the direction that we're taking. We could talk why it's taken so long to get to a point of really talking about this idea of citizen engaged HIV implementation science, but the good news is that this is where we are now, at least from my perspective, is doing a much better job of using community-based participation. So it's not new to implementation science, it's just we're now starting to put these things together in really meaningful and impactful ways. So there's lots of folks to thank for what I just shared with you, people I've collaborated with over many years, and I thank all of them with my whole heart, and thank all of you for listening. I lead an NIMH-funded implementation science hub, which is one of a network of hubs, and you'll hear from Dr. Sales here in a little bit, who leads the Emory-based hub. We have had an amazing time over the past several years supporting projects that are within the HIV Epidemic Initiative. And I've actually rarely been part of such a collaborative network of scientists and researchers where we really enjoy working together and doing what we can together to advance the field. My own hub had workshops and what we call beachside chats, totally free and accessible. So mostly, I would say mostly methods workshops, but all the stuff I talked about today, we probably have a workshop on it. And then I'm sure that Priscilla will share information about her hub as well, that other folks who we have with us today are part of as well. So thank you so much for listening. Thank you so much for being here today. And I really look forward to our journey today during the workshop. So thank you. And I'm happy to take questions, comments, thoughts, anything that might be on your minds.
Questions, comments? I just have one comment.
Good morning. I just have one comment, and I enjoyed the conversation.
What's your name and where you're from?
I'm sorry.
Yes. That's okay. That's okay.
First of all, I'm Daenerys Henderson. I represent the Community Liaison Council for the Center for AIDS Research. And I love, through your whole entire conversation, that you ended with the fact that we cannot do this without community-based organizations and community implementations of any project or any end to the epidemic must start and end with community. So I just want to give you kudos for saying that, and that I appreciate it. Thank you. I appreciate it.
First, great meeting you, and just a wonderful presentation. Dr. Consultant with Satcher Institute, and just a wonderful, wonderful organization, particularly around but I wanted to know, in your research endeavors, what are some of the most salient barriers that you have come across given the current culture? Politically.
Big question, which I thought we might come across today. Remember, I am here as a private citizen on vacation. I mean, one of the things that we address in any political climate is attitudes. You know, and they make a different attitudes of resistance, denial, stigma. These are persistent barriers over time, over space, over geography. Resources, shifting resources is a huge barrier. Really, honestly, regardless of where we are in history, resources change in any given political climate. And that is one of the barriers that we hear about, especially when we're doing work in community-based organizations. Because as I mentioned before, even organizations, and this was many years ago, but organizations that wanted to do the interventions that we had to offer couldn't, because they didn't have the personnel or something was taken away. Some budget was slashed. They had to double up on services. Maybe they lost their space. Maybe they lost personnel and turned over and they couldn't replace them. So these are the types of barriers that we're probably always going to see in one way or another. But I think that question and issue of attitudes and philosophies, let's put it that way, can really get in the way of progress and can actually set us back, which would be more than unfortunate, because a lot of progress has been made. And we don't want to lose it. Huge barrier when some people, organizations, populations get more resources, more attention, more time, more energy than others. Those are going to be very challenging barriers to address. Made tremendous strides in that way. And it is hard work. And I think even a barrier as a researcher is that, that just perseverance, like when you face a lot of barriers and challenges, it can be hard to keep up the motivation, the spirit, the commitment. But at the same time, from my perspective, as just a person, we have very, very pressing public health issues to address that are not solved. And we are not going to achieve the goals of the ending the HIV epidemic if we aren't persistent and resilient and persevere through the many, many challenges that we are even on this very day in our own organizations and in the country and in the world at large. So, I mean, there's so much to be said about that, and I hope that's something that we can talk about throughout the day. And I hope that my response is getting at just a touch of the passion that I feel about your question, which I'm, trying to raise in. But I feel the question, and I do something that we are in a space to be able to have sound on that today. So I appreciate it.
Thank you.
Hi, my name is Kennedy Loman. I'm a co-founder of Lotus, and Lotus is a private support network for women living with HIV, cisgender women with HIV. So my question for you is, has there been any framework or theory that you all implemented as far as getting involved in the community and bringing the community?
Yes, I think, and I would love for our panelists to weigh in on that as well. This panel or the next panel. I think that the ones that are helping the most, at least for the work that I've been doing, have been those rooted in community-based work, which again, were not designed as part of implementation, research, or science. They've been around a long time. There are a handful, I would say, of equity-oriented frameworks that have been developed really mostly over the past 5 years. In implementation science, like more specifically, that bring in a lot of that current community-based work. So I think that there's a framework that I really enjoy using lately. It's called the Transportation Framework. And it is very much rooted in engagement and community-based work. By not only said colleagues, I'm happy to share that citation with you. And it's one that it's, every step is a partnered step. Every step is a collaborative step. So there are steps that we take from thinking about the idea to actually doing and looking at our outcomes that are done by collaborators who are kind of the end users of the work that we're doing. And so that's one that I've been using a lot lately. That's been a really good fit. And then again, it's really practical and it has like 7 steps. And so you can really see, am I on step 3? Am I on step 4? So I love like something that has the ideas and the concepts in it, but that also gives me a really practical way to do it. Because otherwise I don't know how to use it. So I'm going to kind of make it up as I go along. So the ones that come with, here's a series of steps you can use. And not that it happens in such a linear fashion, but you can at least have those sort of guideposts where you use it. So yeah, great question. And I'd say there's a growing number of frameworks. But initially, a lot of the theories and frameworks that were being used in this field did not do enough of what you're asking about, in my opinion. So we're seeing that evolution. Sure. Thank you. Thank you for the wonderful questions. I'll hand it back over to you. Are we taking it? No. Okay, great. So we are going to move into our panel discussion, which I'm very excited. First, we're going to hear from Dr. Bonner from RTI International. Dr. Bonner is a senior research clinical psychologist at RTI International. She's worked with people living with and affected by HIV for over 10 years and is very passionate about HIV prevention. Her research and publications focus on understanding the impacts of gender-based and developing sustainable interventions. There's that word, sustainable interventions to address these challenges. Her current projects seek to understand how to integrate all of your services to address barriers between treatment and prevention access. She earned her bachelor's from Florida A&M, her PhD from the University of Memphis, and completed postdoctoral research at the Yale Center for Interdisciplinary Research. Dr. Bonner, welcome.
Much for that lovely introduction. But today I will be sharing with you some part of the geographic of the Scientific National Institute how to do that these through nursing and learning. And this project actually sought to support providers and private healthcare spaces, prevention, to level. I want to acknowledge my investigative team that helped to implement the work. To my colleague, Bishop Brown at RCI, my dear collaborator, David Diallo, with an infectious disease physician at the UNC Chapel Hill, and Wendy Wexberg, who is a psychologist and force in the field is what I call her. Also RCI. So a lot of what we know about HIV and young women and all of my colleagues in the room have helped us to understand. But what we know is that Black women are more likely to and that they, when they account for a large portion, they somewhere in the neighborhood, at least 50% of HIV cases in women, they only account for probably less than 2% of these patients. OBGYN, family medicine providers in the Atlanta area don't provide that to their patients. So I was at the stop here, objective observer in this work. I'm a Black woman, and when I moved to Atlanta, I quickly found out I was pregnant with my first child. So I was going to the doctor, right, and I could never find anyone to put me in the right direction, to give me a referral, to write a prescription. It makes like my second child, and still not been able to get back in the area. And private insurance, educated, all the things that we say that you have to be to access healthcare. Tell that story and this is where my passion and interest in this work. Because it is true that one of the places that you go to receive care in the metro area. But women with insurance, women with means, and so that is the foundation of this work. And so what we know is that we want PrEP and desire PrEP and prefer to see receive it from infectious disease in general. So they're in position to want to get it from their regular care. And so this research really focused on engaging communities to understand what are the needs of Black women in the metro area, what are the needs of providers who are interested in providing PrEP, but they don't really have the capacity to do so, and then to develop training to help providers feel supported in the provision of prior care spaces, and then to test that training, and then so I'll kind of walk through each one of those steps. We are here to talk about today how we have used some of the theories and frameworks and outcomes that Dr. Hamilton discussed to think through how we think this might work. Right? Patient stage, before we develop anything or test anything, we had focus groups and we tried to determine, okay, what are the drivers of some of the issues that we're seeing? Like, what are some of the facilitators? Like, providers are very excited about PrEP, but then what are some of the barriers? Like, well, I don't know how to reimburse for it. I don't know how to bill for it. Like, for the women, like, oh, I didn't know it was for me. All the commercials that I see don't really indicate that that was for me. So wanting to really understand all of those factors. And then once we have them change those factors, kind of Dr. Hamilton listed the list of strategies. So we kind of picked what would be our first step. And surprise, surprise was education. So we decided, okay, first let's educate why it's appropriate for Black women, because providers are people too, they're saying the same commercials, they're saying the same narratives. So they might feel like they don't have to know about it because it doesn't impact their patient population, right? Because conversations on the HIV. What do we think that? But that's, you know, that's part of the narrative. So, educating providers about, the need for PrEP, particularly about among Black women, and then how to do it. And then our hope was that by educating them, that we address kind of this knowledge gap, increase their self-efficacy or their confidence to PrEP, and then and then we and that is based on Proctor's taxonomy, which I was going over. So the acceptability of PrEP itself for patient population, the feasibility of providing PrEP to their patients, the appropriateness of providing PrEP to their patients, and then the acceptability, feasibility, and appropriateness of training itself. And then lastly, what we all want is for providers to. And in order to do this, we had a community engagement throughout. We did focus groups and, with Black women and interviews with providers. Those were guided by the consolidated framework research that I kind of just went over. Other than that, kind of figuring out what are the levers, what are the drivers of implementation. Which Dr. Hamilton is in my mind the mother of. I'm not sure if that's true or not, but that's what I say. I did a seminar and I'm like, yep, this is it. This is what I'm going to be using center design to develop the training and then have a pre-post assessment based on the outputs that I just went through. So for our focus groups, we recruited African American women here in the Atlanta metro area. Essentially, they had to report being HIV negative and report having vulnerable sex in the past 6 months. I attempted receiving care at a private healthcare center here in metro areas, specifically for any of the epidemic jurisdictions. So like Fulton County, Adams County, Warwick County, and so once they showed interest in the focus group, they consented. We had the focus group virtually, this was all during COVID. After focus group, they were compensated, and then we transcribed and analyzed the data. So we had a total of 22 women, but I don't know if everyone can see this, but I think that I was a very diverse group of women. So most women were single, most women had private insurance, income was extremely diverse, $25,000 and $100,000 a year. Most 68% of women had a college degree or higher, and the average age was about 33. And I like to pause here because I think sometimes we forget about women who can afford medicine, they can go to their private OBGYN and just ask for PrEP. And so I was really happy to see that we were reaching women who seemingly had all the resources, personal resources to access PrEP. But we know, and I know personally, maybe have some other barriers to accessing PrEP once they do go to those healthcare providers. So these are different quotes from a focus group. I really like this one about barriers to communication. So it's if it's not advertised in some way, it's a woman might not feel comfortable asking because she may not know, whether the doctor's aware of the drug or doctor even feels confident or comfortable prescribing the drug, right? So like this idea that patients are going into a doctor's office and they are trying to adjudicate for themselves these symptoms. Doctors are actually vacation, then they ask for this drug that the doctor can give it to them, whether it be a brochure in the waiting room or something on the wall. So those things are very important. It says, I think it depends on her. If she has a primary care or OBGYN, that's really where she would regularly go. She has a relationship with that provider, then maybe she might feel more comfortable. So this idea of being already offered. And then the preference of setting, if she has access to health insurance, then I think her OBGYN would probably be her preference. So I think that's probably what we see in the literature is generally true. People have found someone they've already established a rapport with, they want to stay with that provider. Right? So then based on the focus groups and interviews with providers, we developed this training, it's online training. It's actually hosted, I think, at the Georgia AIDS Education Training Center. Providers can go take it and get medical education credits, the training looks like. So the first module is about the epidemiology of HIV, particularly in the epidemic areas, particularly around for Black women. So providers can go and click to see if they are represented in the area. Although the work, you can see what the epidemiology is. We talk about structural reasons for the epidemiology being what it is, the kind of get away from the person are living in the metro area or practicing in the metro area that Black women who are coming in for reporting crimes that should be offered. Right? It's not about how many partners have been at or is your partnership or it's like we don't even have to go down that road. We know just by creating where we live, the women are engaging in conversations that should be offered. Right? And so that's kind of the gist of this module. There's 6 others. So there is the epidemiology, the basics, definitions, there's kind of the medical protocol and how to implement both oral and prep and oral and injectable prep. And the differences, individual prep, optional and persistent women, as well as prep and pregnancy and how you handle side effects and zero. So then after the training was developed, we moved into pilot on time. So this one was say, like we're in the school of medicine, and how do we do this work? Particularly in implementation science, particularly when we're working at the provider and organizers that engage in this work. We encourage folks who are in healthcare spaces to support this work. Is this good? So the providers who were interested were considered online. They took a pre-test. Based on their pre-test, they were recommended certain modules of the training to take. They could take all of them. They were recommended some, just make mine for people's time. They took a post-test, and if they had 85 or above on a credit knowledge questionnaire, they were directed to get CME credits. And so we had 14 providers. Here you see some of them completed the training, some of them didn't. So 8 completed the training, 6 did not. These are just some quick graphics. Most folks were physicians, but we had a physicians, very diverse across racialized groups and then they were all concentrated in southern epidemic, Florida, South Carolina, North Carolina. So these are our results. So I'll start with the prep outcome. So basically, as appropriate for your patient population, it was acceptable to prescribe PrEP. And do you feel like it's feasible for you to prescribe PrEP? And after the training, all the providers had pretty high ratings on those. And I am most interested in is if they actually prescribe PrEP. So these providers had never prescribed PrEP at all and had never received any PrEP training, but immediately after the training, had identified an average of almost 5 patients, could have been a few patients, and prescribed PrEP to about 2 patients. And then they also had pretty high moderate rankings of the take home message is really, I think we're moving in the right direction, but the meaning is still overwhelmingly kind of mental focused around PrEP. We know that a lot of women aren't interested in PrEP design. And they value the recommendation of providers. And so I think, as much as we can support our providers, particularly our OBGYNs, and providers in that space, primary care providers. I think that's kind of the golden entry, right, to having Black women have increased access to them. And for providers, I think people are open to providing PrEP people, but are not necessarily shut in PrEP. But I think that they don't know how to engage women around the issues of HIV. It's still a new conversation that even sexual and healthcare providers are still trying to figure out how to navigate. And it was encouraging to see that they found training to be acceptable. Feasible, and a conversation to pray. So I just want to say thank you to all the women and providers who participated, outreach funding, search for the RCI, the UAV implementation science, provided support for this project. I think for us,
You take 1 or 2 points. Is that okay?
You can explain to me exactly what PrEP is. I'll just say my age group, you missed that knowledge. Okay, so I'm sitting here taking notes. I get your background. I was like, what is that? And at my age, should I be requesting that of my doctors?
I just highlight exactly what we're discussing about the narrative and how of the point the narrative is missed. I mean, it's like one of generally, I think across age groups. You're not a good company. So PrEP is the long name is pre-exposure prophylactics for HIV prevention, and all that means is that it's medication that you can take before where you're exposed to HIV, and should you be in contact with the virus. And so right now there's an oral version, but the trade in with the brand is called Truvada, but then there's a generic available, and then there's an injectable version of the trade name is called Opportunity. The generic version is called Pembrolizumab, but the marketplace there's no generic one, so it's called Opportunity. And yes, I think everybody, every time I go to the doctor, I ask them for PrEP. Do I have to personally need it? Maybe not. But I think that like the more providers are hearing their patients ask them, it encourages them to say yes. And I would also say there are a lot of resources online. I'm sure we have resources back. There's a wonderful campaign that we just have called the Reasons that offers a lot of information about prep options for Black women. So I encourage you all to take advantage of those resources as well. That's
You targeting, or are you targeting vigorously those single women under 40, or are you?
Or is that, are you having challenges? Because to me, this should be in churches every Sunday morning or every, you know, where that population
people in that.
is, or sororities, you know. I just wonder why this is a secret, you know. Okay, thank you.
That's true. That is a $1,000,000 question. So we absolutely are, and I say we, I know some people sitting up here. Yes, Lotus, I know, Sister Love, there are lots of people in this space, that have really done a lot because we were asking the question, why is it still a secret? We have so many Black women are requiring HIV. So that is the thing.
Take this to my church.
I just want to say, for how long PrEP has been around and available for women? That's what you really, because it is insulting, actually, to know that you don't know about it as long as it has been around and as long as it has been available and accessible for Black women, period, of all ages that are engaging in condom sex. So that's the part that we need to be asking. And why are there still gaps? Why isn't it very much announced and advertised on television as it is for other populations? That's where we need to be getting to. And I also wanted to ask if Empower Her is still going forward, and if it is, are you routing to communities in rural areas? So, PrEP is essential to get to the end of this epidemic. But why isn't it? Maybe, you can address that a little bit.
Yes, so it is still available online. So that way, yes, it's forward. So I think my bio is to stay one. So we really are trying to create things that outlast current and outlast. Yeah, training is still available online. And I'm happy to share that with folks who are interested. And in terms of rural areas, we actually just submitted an RN1, such as a grant application to NIH January 9th. Dr. Chandler and I try to expand it to rural populations. And so that's a huge part of that project. So we will see. Yes, that's our state expansion.
So we have one question in the chat from Stephanie Henderson from the CDC Division of HIV Prevention. Says she's a fan of the work of infections. Within the field of implementation science, are scholars and practitioners using human-centered design framework to inform HIV prevention, testing, treatment, care, and stigma preventions, if so, how?
I will say yes, very much so. And in an effort to hype up my analyst and not still I'll let her talk about Dr. Sales talk about work that she's doing. But I think generally as teams that are designed, and user design, there's different ways of saying that it has really made its way. It's implementation science as a way of, I think, different strategies and interventions. And also, engaging the end user, right? So in this case, it's the provider. So we want to make sure that we are creating something that a provider will find. Useful and helpful and engaging. And so I think that's a core tool, the toolbox of implementation science and develop some of the strategies. Thank you.